Okay, so the presentation will be done by myself, Hilda, and Ken. Our case study was on cryptic cachexia. So our patient was a 57-year-old man with a history of rectal adenocarcinoma for which he has undergone colostomy, and he presented to the emergency department with an unintentional 22.6 kilogram weight loss and malaise, which has been occurring over a period of 6 months. So his history of present illness during this time, which was the 6 months, his body mass index has dropped from 23.9 to 16.6. Sorry, I was just reading the chat. And he is displaying, he has noted progressive weakness, which has limited his ability to complete activities of daily living. He has noted abdominal distension and leg pain. He says he has not been experiencing any nausea, vomiting, anorexia, joint pains, fevers, or cough. And it is noted that he has noted soft brown formed colostomy output without associated blood, mucus, or illness. His past medical history. So the patient was diagnosed with stage 3B, T3N1 AM rectal adenocarcinoma after undergoing colonoscopy for hematochezia. His treatment had consisted of neoadjuvant chemotherapy, external beam radiation therapy, and an abdominal perineal resection resulting in colostomy. The patient had undergone regular surveillance colonoscopies. The last one was 3 years prior to his presenting today, or to the emergency department, a CT scan, which was 9 months prior, and carcinoembryonic antigen measurements, which was 6 months prior, which were all negative for recurrence. His family and social history. So his social history, he is a lifetime non-smoker. He does not drink alcohol or use recreational drugs. He has no history of homelessness, imprisonment, or known TB exposure. He has no changes in his eating habits, and he follows a well-balanced diet. The patient lives alone, and he had worked as a mechanic. He has not had any sexual contact in more than 2 years. And the patient's medications include ibuprofen for back pain that was ameliorated with physical therapy. The patient's family history. His mother had stomach cancer. The patient was born in Puerto Rico and is of European ancestry. However, the patient moved to Connecticut at the age of 19, and he also last visited Puerto Rico 8 months prior to his visit. So physical exam of the patient, his vital signs, his temperature was 37 degrees Celsius. His heart rate was 110 beats per minute. His blood pressure was 94 over 60 millimeters of mercury, and he displayed shallow breathing. On inspection and palpation, the patient appeared cachectic. There was noted wasting of the arm, leg, and temporal muscles. The patient displayed horizontal nystagmus. The buccal mucosal was normal without chelosis or any abnormal pigmentation. There was no cervical, axillary, or inguinal adenopathy. There was a protuberant, non-tender abdomen with shifting dullness. A colostomy bag in his left lower quadrant had a pink patent ostomy with brown formed stool. There was noted hyperpigmentation of his distal lower extremities with hypopigmented macules and no edema. And that finding can be seen in the photo here on the bottom right. No other hyperpigmentation was observed. And the motor strength was 4 out of 5 in the hips and shoulders and 5 out of 5 in the biceps and knees.
Okay, I will take over from here. For the laboratory study, first of all, can you guys hear me? Hello?
Oh yeah, Ken, this is you.
Okay. So for the laboratory studies, for serum hematology, his white blood cell count was 7,900 per cubic milliliter. and his hemoglobin was 9.0 gram per deciliter, and his um, his MCV was 82.6 F liter, and RDW was 19.9%, and reticulocyte count was 1%. And his platelet count was 164,000 per cubic milliliter. And for differential diagnosis, this three point is important. His neutrophil was 94%, and lymphocytes was 2.5%, and his for general chemistry and biochemistry, his iron was 19 microgram per deciliter, and ferritin level was 322 nanogram per milliliter, and his vitamin B12 was 621 pg per milliliter, and for his folate level was 20.5 nanogram per milliliter, and his ALT level was 84, and AST was 82, and ALK was 157, and his albumin level was 1.6 gram per deciliter, and total protein was 6.4 gram per deciliter, and pre-albumin was 77.6 milligram per deciliter.
Can you please comment on those values? Because we can read also, but can you tell us what was outside of normal range from values you just told us about?
Okay.
Thank you very much.
Okay, so for that, his iron level was 19 microgram per deciliter, and reference range is 3.4 micromole. No. 60 to 179 microgram per deciliter is reference rate. Reference range, and his ferritin was 322 nanogram per milliliter, and the reference range for that is 18 to 370. And his vitamin
Just tell us whether it's increased or decreased. That's pretty much all I'm asking.
Oh, okay. Within the normal range for ferritin and vitamin. Okay, should I start from the beginning?
No, it's fine. Iron was low, I understand. So
Yeah,
15
okay.
was normal.
Okay, and vitamin B12 was high, was normal, and folate uh, was more increased, and his BUN and creatinine and total bilirubin were normal, and morning cortisol and thyrotropin and glycate hemoglobin were normal too. Continued laboratory studies for cell logic. His transglutaminase IgA antibodies were negative, and HIV was negative too, and hepatitis A and B and C were negative. And C-reactive protein was found for 86.9 milligram per liter. And for urinalysis, we traced protein, and protein creatinine were 0.9 milligram protein per milligram creatinine. And for histoplasma antigen were negative, and peripheral blood smear was hypochromic and normocytic red cells with increased bands. For diagnostic workup, A CT scan of the chest, abdomen, and pelvis was done, and there was large amounts of ascites were found, and retroperitoneal lymphadenopathy was found, and no abnormalities in lungs, liver, spleen, bowel, and kidneys. Next slide, please. And for diagnostic workup, we did paracentesis of abdomen, showed serum ascites albumin gradient of 0.6 gram per deciliter, and white cell count of 47 per cubic milliliter after red cell correction. The neutrophil count was 12 per cubic milliliter, and the lymphocyte count was 10 per cubic milliliter. The total protein level in a sample of acidic fluid was 4.5 gram per deciliter with an adenosine deaminase levels of 24.4 unit per liter. This is higher than reference range. And cytologic examination showed no malignant cells. And 24-hour urine protein measurement showed 410 milligram of protein. The stool alpha-1 antitrypsin level exceeded 1.13 milligram per gram of stool, and this is higher than reference range. And serum and urine protein electrophoresis with immunofixation revealed no discrete monoclonal gammopathy, and the serum free light chain ratio was normal. And quantitative immunoglobulin measurement showed an IgG level of 2080 milligram per deciliter. This is higher than reference range. And IgM level of 30 milligram per deciliter. This is decreased than reference range. And IgA level of 1360 milligram per deciliter. This is higher than reference range, and analysis of IgG subclasses showed an IgG1 level of 1224 milligram per deciliter. This is higher than reference range, and IgG4 level of 194.2 milligram per deciliter. This is higher than reference range. Next slide, please. Continue diagnostic workup. So for stain of acidic fluid for acid-fast bacilli and polymerase chain reaction assay for tuberculosis were negative. And a sample of acidic fluid was submitted for mycobacterial culture. Examination of a specimen from a CT guided retroperitoneal lymph node biopsy revealed non-necrotizing epithelioid granulomas and a polymorphous lymphoid population. And Grams and acid-fast bacilli stains were negative for bacterial organisms, and pathological examination showed no evidence of malignant cells and no increase in IgG4 positive plasma cells. And crocodmesanamine silver staining and periodic acid chief, which is PAS, staining were negative for fungal and other organisms. Next slide, please. Continue with colonoscopy with biopsy. Showed mild active colitis without granulomas, crypt abscesses, or dysplasia. And esophagogastroduodenoscopy with biopsies showed gross evidence of diffuse active duodenal inflammation with no increase in intraepithelial lymphocytes and no flattening of intestinal villi staining for acid-fast bacilli and PCR assay for tuberculosis were negative. And an extensive focal collection for foamy histiocytes in the lamina propria of the duodenum was identified and showed diffuse uptake of pus staining, which you will see soon. Okay.
Okay, so on duodenal biopsy for panel A here, it's a hematoxylin and eosin staining with a low magnification view of the duodenal biopsy specimen, which shows a slightly broadened villi with focal collections of macrophages. And for panel B, which is a high magnification, showing aggregates of foamy histocytes on periodic or foamy histocytes. And then for panel C, there's a collection of foamy histocytes in the lamina propria, showing strong cytoplasmic positivity. And for panel D, which is also a high magnification view of the foamy histocytes, showing many PAS positive globules that vary in size and many rod-like structures as well. These are all feature characteristics of Whipple's disease. And next. And so this is just a repeat slide of panel D, which is a magnified view of the past stained specimen with presence of rod-like structures, like I said, are characteristic of Whipple's disease. And a PCR assay of the duodenal biopsy specimen was done, which was positive for Trichoderemia Whipple. And so on repeat physical examination, there was presence of episodic convergence nystagmus on mastication, consistent with oculomasticatory myorrhythmia, and these was suggestive of CNS involvement in this patient. However, lumbar puncture to confirm CNS involvement was unsuccessful. So the diagnosis for this patient was Whipple's disease, and together with oculomasticatory myorrhythmia. For treatment of Whipple's disease, the standard therapy is a 14-day course of ceftriaxone, followed up by a 1-year course of trimethoprim sulfamethoxazole, and there is a possible recurrence on standard therapy, which would then be indicated for alternative therapy. And to actually switch over to alternative therapy, there needs to be a positive PAS staining macrophages, as well as positive trichoderemia replay on PCR testing. And for alternative therapy, it would be a 14-day course of meropenem, which would then be followed up by a 1-year course of trimethoprim sulfamethoxazole. And on standard therapy, a previous clinical trial showed a 95% remission rate. However, in some patients there was a recurrence, or there's always possibility of recurrence, and that would then, if there is recurrence, then you need to start alternative therapy. So for this patient, there was the gyrus-Hexheimer reaction occurring in this patient, and it's actually a rare reaction which has been reported to occur after a patient is started on antibiotic treatment. It classically presents with fever, hypertension, respiratory failure, and even altered mental status. And it's due to the inflammation response to endotoxins released on bacterial death. In this patient, there there was marked clinical improvement within 1 month. However, the patient was lost to follow-up, and so there were no results stating there was actually remission or recurrence of Wickles disease. And in general, patients have a risk of recurrence, and this recurrence would be potentially fatal if it's left untreated. And that's it. Any questions?
Wonderful. I have a submission of questions from group 5, 2, and 3. So, and I will have also one question. So this question goes to the first presenter, Samantha. What is, can you open the first slide of the presentation, please? So, well, actually, the first one, number 1, right? So the but this case study says cryptic cachexia. What is a cachexia actually, or cachexia, like to pronounce it? So how we understand what is the meaning of cachexia, what causing cachexia, and so
on? Cachexia would be, I guess, synonymous with it would be wasting. And so you get extreme weight loss and muscle wasting and loss of body fat. And it, as far as I understand, it's typically due to malabsorptive issues and protein losing enteropathies.
Mm-hmm. And probably we also need to remember cachexia is most commonly develops in cancer patients. All right, and very good. So let's go to the questions from teams. Team number 5. What are the common mediators of cachexia? So this goes to the Yeon question. So that's actually relative to STEP exam question.
Okay.
Maybe if Yeon not able to answer, so maybe the next member of the team, Hilda, can answer.
Common mediators of cachexia, I think, would be weight loss, muscle atrophy.
No, mediators, it means chemical mediators, probably, like what kind of cytokines or interferon, what kind of molecules are mediators?
TNF alpha and interferon gamma.
Very good.
And also interleukin 1 and interleukin 6.
Very good. Okay, so those are indeed considered one of the most important mediators of cachexia. Very good. So, and one more question, guys, for you. Do you know where was a do you know why there was presentation of hyperpigmentation in the physical exam? So this is a question from group 2.
Yeah.
Please go.
The shin of the patient has hyperpigmentation, and it could represent vascular insufficiency and or an endocrine disorder or malabsorptive syndrome. So before the Addison's disease was possible, but given the systemic symptoms, it is typically associated with diffuse hyperpigmentation, and particularly involving skin creases or oral mucosa, vitamin B12 deficiency in rare cases, and that could lead to hyperpigmentation too.
All right. Okay, thank you very much. So that's the answer regarding hyperpigmentation, and I think it makes sense. Also remember that most commonly indeed hyperpigmentation is consequence of 2 conditions, is adrenal insufficiency when we have very high level of ACTH in the blood, with like patients with some tumors, pituitary tumors, or some lung cancers which producing ACTH. So patients may also have hyperpigmentation. In patients with Addison disease, right? So also have hyperpigmentation. So, but probably it's one. A second reason for hyperpigmentation is defects in insulin signaling pathway, which stimulate growth of keratinocytes. I don't think this is the case here. So, because it's usually associated with obesity, acanthosis nigricans. So, but in this patient, probably it's related to ACTH increased level. Could be also other reasons. Maybe it's a deposition of iron in the skin, but I'm not sure if iron level in this patient was high in the tissues. I think Yeon would try to explain us what was iron level in this patient, but I don't remember exactly what he said about iron. Maybe Yeon can clarify for us. What was iron studies in this patient? Was he overloaded or underloaded with iron?
The reference range for iron level is 60 to 179 microgram per deciliter.
So what does it mean?
He had low iron. Sorry, I just.
He had low iron. Good. What in the serum iron? What about storage iron? Remember, iron which is stored in the tissues. How we determine by measuring level of what substances in the blood?
Ferritin?
Yes, absolutely right. So
Normal.
Ferritin level was normal, so not increased. So it's definitely not because of iron with hyperpigmentation. Good. All right. So, and the group 3, I see one more question is a focal collection of foamy histiocytes are results of what? So who would like to answer on this question from your team?
Hilda, do you want to answer? I took your thunder last time. So normally histiocyte formation is a collection of macrophages that are failing to destroy the what they see as the invader, which in this case would be the whip or like I don't know how to say it, the Whipple disease. So
Trophima
yeah.
Whipple.
And so yeah, you get the collection with accumulation of their cell membrane components, so they stain positive with the periodic acid Schiff assay.
All right. Okay. Thank you very much. So that's correct answer. Thank you.